to the Leo Training Podcast with Joe DeLeo. You'll hear in-depth interviews and tips from world-class athletes, coaches, and industry-leading experts to help you train smarter and improve at what you love to do. Train smarter, get stronger, move better, race faster. Here's your host, Joe DeLeo.
We're back with episode 42 of the Leo Training Podcast. And this week's guest is my friend, Dr. Shante Cofield, aka the Movement Maestro. So let me tell you a little bit more about Shante. Dr. Shante Cofield attended Georgetown University, and there she earned her Bachelor of Science in Health Sciences. She then went on to New York University and earned her Doctorate in Physical Therapy. And during that time, she also earned her Certified Strength and Conditioning Specialist certification through the National Strength and Conditioning Association. Shante continued her education and went on to earn the Functional Movement Screen certification and Selective Functional Movement Assessment certification. She is also an Orthopedic Clinical Specialist. In addition to her clinical experience, Shante also teaches for Rocktape. In this interview, Dr. Cofield and I discuss regional independence versus regional interdependence, as well as why the site of pain is rarely the problem. And finally, we spend a good chunk of time discussing what pelvic floor dysfunction is and some possible resources that you may want to check out if you are experiencing pelvic floor pain or dysfunction. So sit back, relax, and enjoy this brand new episode. Dr. Shante Cofield, welcome to the Leo Training Podcast. Thank you so much for taking the time to come on to the show on your Sunday afternoon.
Thank you so much, my man Joe. I know it's been a while. We've been trying to connect, but your patience is greatly appreciated. So thank you for having me.
You're welcome. I'm very excited. Yes, this one's been in the works probably a good 6 to 9 months, somewhere in that range. So we've both had a lot of life events going on. You did a cross country move, changed jobs, you got married. So there's a lot of life change happening for both of us.
Life happens.
That's right. So I'm very excited to have you on here. We've connected through social media. Both have a fellow colleague in Dr. Perry Nicholson. So following a lot of his work and everything. And I'm excited to have you on and talk about what you're doing currently out in LA. But before we get into a lot of the topics we have down, I would love for you to take a moment, introduce yourself, let people know your background, what you focus on when you're working with your students or clients, and what areas that are of particular interest to you.
Yeah, sure thing. So I got introduced to physical therapy when I was about 15. I blew up my ACL, very common, the unhappy triad. I was a big soccer player. I blew it out actually playing basketball. Went through PT and came back and played Division I soccer at Georgetown. And during that whole time, and even before then, I was always like, I want to be an orthopedic surgeon. I want to be an orthopedic surgeon. And that's kind of the route that just kind of had the blinders on. And then I took all the pre-med prereqs and everything like that. And time came to sign up for the MCATs. And I was kind of like, I don't know if I want to do this. And my advisor at the time was like, how about PT school? And I was like, I guess. I was exposed to it within or during my own rehab. And I was like, all right, let's see what this is all about. So I applied to PT school, got into PT school. In full disclosure, I hated it. I felt that during those 3 years that I kind of had made the wrong decision and I should have gone to med school. My best friend at the time was also at NYU, and she was going through the med school program, and we were talking. I was just like, I think I made the wrong decision, but I'm going to stick it out. I graduated, started working, and still was not happy. Just felt that the model didn't lend itself to me doing what I wanted to be doing and delivering the quality of care that I wanted and having the amount of interaction with patients that I wanted. So, I spoke with my advisors again, or they were advisors when I was in PT school, and I went back and spoke with one of them, and she was kind of like, keep learning. She's like, speak to this other guy. His advice was sign up for the OCS, which I did. I switched jobs and went to a different clinic, and that's when I started doing pelvic floor work. And I just wanted to learn. And that lends itself to a ton of learning, a ton of growth. And within that time, I was taking a lot of continuing education courses and stumbled upon Rocktape, took that course, and honestly, it changed my life, Joe. I took it with Perry Nicholson, and I was just like, this is the road that I want to be taking, not just in terms of teaching, but in terms of treating and helping myself. Because I was having a lot of knee pain and knee problems at that time. And, Rocktape, that course is so much more than just taping. It's a movement course. It's all about movement. And so I got into that, and by the grace of God became an instructor, and that's kind of led me to where I am today. And my model has become very different, where I got that job as a Rocktape instructor, and then was able to quit my regular 9-to-5 PT grind, and start seeing people privately, start seeing people at my CrossFit box, teaching, which is absolutely my passion. And then some of the people I see, and I'm glad that you use the word clients and students, because it went away from I have patients to I have clients, people I'm working with privately, or I have people who literally just want to connect and talk about movement. And, we could be students together, and making that into a model in and of itself. And it's just been an incredible ride. And basically now my ideal demographic, if you will, is anyone who's interested in moving better, irrespective of their age, irrespective of what they do for fun, for a living. You could be 97 years old and you come to me and you're like, I want to move better. That's the person that I want to be working with. And that's kind of where I'm at right now. Right now, I'm currently doing a lot more teaching than treating. So like you said, I just moved to California, so it was easier for me to set up more teaching gigs and then immediately build my client base. But that's shifting, and I'm continuing with a lot of teaching. But probably in the upcoming months, I'll start doing some more treating and enjoy this life that's been created so far.
Outstanding.
In a nutshell.
Awesome. Well, congratulations. That's very, very cool. So out of curiosity, if you don't mind sharing, so what, initially when you first started off, in the physical therapy world, what are some of the things that kind of frustrated you about not in that model? Was it not having the time you needed to work with people, or just the environment? What were some of the frustrations you had?
I think it was a little bit of everything. Definitely the time, and it's kind of built in with insurance. Reimbursement is what it is, and so oftentimes you have to see more patients in order to turn a profit or keep the lights on, and I understand that. But for me, it was kind of like, I'm seeing this person. One clinic I had, it was 30 minutes total for the whole entire treatment. And it was kind of like, if that person came late, because, it's New York City, that person gets hung up on the train, they come late, suddenly you're down to 20 minutes with this person. And I'm kind of like, how much change can I really affect with them? And how well can I get my message across within this 20 minutes? So, and I'm kind of like, well, I'm seeing this person 20 minutes, twice a week, that typical 6 to 8 weeks. Like, are they getting better because they're seeing me, or simply because 8 weeks has passed? And for me, I'm always about asking myself, what's the most efficient way to do this? Is there a more effective way to do this? And I kept running into that at the end of the day and being like, I could be doing this better. This person could be getting better if I could see them longer, not necessarily to do more manual, but just to have more time to explain things or work on more movement patterns to kind of grease the groove with things and get better carryover. And so that was primarily the biggest thing. You're seeing anywhere from 16 to 24 people in a day. You just get burned out. Like, it's not a sustainable model, in my opinion. And I was like, I really began to enjoy doing PT. And I was like, I can't see myself doing this for more than 5 years physically. You can't pour from an empty glass, as they say. And you come home at the end of the day and you're wrecked. And I was like, this seems like I'm doing something wrong. Let's figure out a better model. And that's when I started looking into trying to change, because you also couldn't grow. You try to take a continuing ed course, but you're too tired, or you don't get as much out of it because you've been seeing so many patients during the week, and you're just so mentally exhausted that by the time the weekend comes, you're like, yeah, I want to take this course, but like, I got nothing left to give. And I'm all about growth and learning. And so I was like, I got to figure out a better model for this. And that lent itself to taking some steps and making some changes.
Awesome. Very cool. Well, at the end of the day, it's all about helping people get better.
Exactly.
So it sounds like you're taking those steps and you're making that happen. It's very cool.
Absolutely.
Awesome.
Absolutely.
So you mentioned Rocktape. I've been through the course as well. I think it's fantastic. Highly encourage people to attend if they have a chance and learn from you, of course. But seriously, it is a great course. I think you made a really important point. It is not just tape. It is about movement. So when I attended, I went through. I was already had attended the FMS level 2 seminar, and so I already kind of had some foundation there. But the thing that I liked was that it kind of exposes you to just more options of looking at movement and evaluating it.
Good.
And then boom, right there, all of a sudden you are that much more equipped to, put together a really good program for an individual.
Absolutely.
You've expanded the toolbox. So I would love for you to talk a little bit about Rocktape, what it is in terms of, the actual the kinesio tape and how that's different from other tapes out there. And then also, what people may learn during that course and some of the takeaways that they can use to help other people.
Absolutely. So the Rocktape, at Rocktape we have a whole series actually of courses, but the basic course is FMT Basic, and we call it FMT Basic and FMT Performance. So those are our level 1 and 2 quote unquote taping courses. And what we introduce you to in level 1 is the actual tape, how to put it on, how it works. And also, like you said, we give you options on how to look at movement, how to assess the body, and then how you can use this tape within that model to help treat pain, to help treat swelling, to help, my favorite, work on movement. Rocktape in and of itself is a type of kinesiology tape. There's a bunch of them out on the market. And the main differentiating factor between Rocktape and other kinds of tape is how sticky it is. It's currently the stickiest tape that's out there, which can be a great thing or maybe not a good thing. It depends on your population. You have an elderly population or population with more frail skin. Perhaps Rocktape isn't the most appropriate, although we do have different levels strength of adhesive. But that's one of the things that I say when I teach the course is I am not here to sell you tape. I'm here to teach you and talk about movement, talk about how kinesiology tape works. You go back and buy whatever tape you want. If you're looking for something that's going to stick better, Rocktape tends to be your best option. But I'm really here to talk about how it works. The 3 main ways that we're seeing it work. 1, decompression, right? The tape wants to recoil on itself. It has stretch built into it. So it wants to recoil when you put it down. We get a lifting effect through the fascia and through the tissue that helps with fluid dynamics, helps with swelling, can help with pain. We see it working via pain mitigation. And at a very rudimentary understanding, we talk about that via pain gate theory, kind of distracting the brain. And then my favorite, the neurosensory effect. You touch the skin, you light up the brain. That can affect movement thousands of times faster than yelling at someone because it's a tactile or kinesthetic guidance.
Right.
Thousands of times. That person that's like trying to get them to squat and you're like, put your butt back, put your knees out, put your butt back. You touch them, you put a band around them, put tape on them, and things change like that because it's kinesthetic guidance. Yep. So within that's how we talk about the actual tape itself. In terms of the course, what we're giving you, level 1 is more so, I call it a triaging course. Your knee hurts, here's how you tape your knee. Your shoulder hurts, here's how you tape your shoulder, so on and so forth. But then we spend time during that day also discussing, why does that body part hurt in the first place? And that's huge. I always say that the most complex part about taping is why you're putting it on in the first place, not how to put it on. Putting tape on is not rocket science. What is the magic, the mojo, as Perry would say, is why you're putting it on. What is that movement dysfunction that's causing that shoulder to hurt? Because 9 times out of 10, the area that hurts is not actually the problem area. It's taking up the brunt for something else, taking up the work for something else, and that's why it hurts. At Rocktape, we introduce you to systems to kind of figure out what else may not be working? We talk about fascial chains as introduced by Tom Myers. We talk about the joint-by-joint approach set forth by Gray Cook and Mike Boyle. And we talk about planar dysfunction and tie in some ideas with that. Just to give the attendees models, and as the word you used was options, of how to look at a body and how to look at movement dysfunction, because no one model or paradigm is going to capture every single patient. So the more options you have, the better you are. And so that's what we talk about throughout the level 1 and 2 courses. Level 2, we tie in more movement and more fascial chain stuff, but you are introduced to it within the first day, which is one of the things I think is so valuable about this, about this course, because we give you this information. And then we show you how tape is just one tool that you can use to affect change within this system.
Yeah, absolutely. It is very powerful. And the skin's the largest organ in the body, or on the body.
Exactly.
So, I'm going to get this wrong probably off the top of my head. But in like 1 square centimeter of skin, I think it's like, what is it? Like 300.
Yeah, I think it's like, I think in the slide we have is like 500 million or something ridiculous, right?
Nerve
like
cells,
right?
Number.
Yeah,
right.
Like so something ridiculous.
That's a huge amount of neurosensory information that you're tapping into the body.
Exactly.
It's and the other thing that I would love for you to explain a little bit more, you touched on it right towards the end there, was that you said that the area in the body that hurts is rarely the one that's the issue. So totally agree with you, and I've seen that and experienced that and have helped some people clear up dysfunctions. But how does that work? Why is if I have neck pain or shoulder pain, why is that bothering me? But it might be my hip, or it might be the thoracolumbar fascia, or something like that. So why is it this one area is causing issues and the problems somewhere else, along the kinetic chain?
Typically, and the way I start explaining it is within that joint-by-joint approach that's set forth, a regional interdependence model that's set forth by Gray Cook and Mike Boyle. And within that model, if you ever look, there's a really nice graphic that they use, and they use the skeleton, and they have the word mobility or stability written next to certain regions of the body, and this alternates. And it's not to say that these regions of the body, that's how they perform, but that when we see dysfunction, these areas tend to lose this. They either tend to lose mobility, they tend to lose stability, and therefore when we're going to try to correct dysfunction, they could benefit from having stability or mobility imparted. So what we tend to see is, in the presence of dysfunction, an area is kind of not doing what it's supposed to do. So another area starts picking up that slack. Let's take something like low back pain, because that's pretty typical, right? Well, something like low back pain, L4, L5, L5S1 dysfunction, everybody has that, come in with that. Well, if I look above and below that area and see what tends to happen, we tend to lose thoracic mobility. We tend to lose hip mobilities because of our inactivity, things like that. And so then we start to pick up this motion at our lumbar spine. It's an area that's not really designed to be doing all of that. And so we start to experience pain there. If I just go in and say, here's the painful area, and start hammering away at that, my pain might go away. Pain's pretty self-limiting. It kind of goes, comes. But I haven't fixed the problem. I haven't addressed the fact that, hey, you don't have thoracic mobility. You don't have hip mobility. And so you're picking up that mobility at your lumbar spine. So I'm just essentially treating the symptoms without addressing the cause. We take it a step further and talk about the fact that in the absence of prolonged immobilization or direct trauma, an area, we tend to lose loss of mobility is typically preceded by loss of stability somewhere else, right? We're always going after the cause. So one of the things that people miss is they'll go after the mobility in the T-spine, they'll go after mobility in the hips, but we haven't imparted stability to the system and made it feel safe, right? Your body just always wants to feel safe, and that's typically why we start to, have pain in one area despite the fact that it's not functioning in another area. The easiest way to impart stability is to take away mobility from somewhere else. And so your body's going to take the path of least resistance. It makes things tight. We start moving through areas that aren't designed to be moving that way. And then we start experiencing pain there. It's kind of like that bend it till it breaks principle. I got to figure out, well, why does it keep moving through there when that's probably not the intent or the role or purpose of that joint or that region. Yes, there's obviously such things as referred pain and radiculopathies and things like that. But because the body works together, right? We're not just piecemeal. We're not Mr. Potato Head. We have to look at how all the parts are playing together. I think people take that approach of like, oh, the arm and then the shoulder. It's all connected, right? We have to see how they're playing together, and not just consider it by itself and say, oh, it hurts there. That must be the problem. Right. There's typically something else going on.
Right. Yeah, I love that. Couldn't have said it any better. That was very eloquently put. Thank you.
Joe. Thank you, Joe.
You're welcome. Very cool. Okay, so is there anything else that you want to touch on with joint by joint approach or Rocktape before we kind of shift into a different topic?
I think that actually, because I know we're going to talk about it later, but I think it segues nicely, is Andrea Spina's FRC course. Yep. And a really nice thing that he sets forth within, or that I picked up from his course, is this concept of regional independence before regional interdependence. So I just kind of spoke, almost ad nauseum before about how things play together and that we aren't Mr. Potato Head. But when we're looking to restore functionality, the easiest way to kind of pick up on things and the easiest way to start restoring that functionality and addressing impairments is to make sure that all the parts are doing what they're supposed to be doing before we get too concerned with how well they're playing with each other. So Andrea Spina has a great system that he sets out and puts forth within his course that just shows and demonstrates, and he has a lot of science to back it up, how to gain motion and mobility at a specific area and how to keep it, right? Because the main difference between this system and other systems is that you're going through ranges of motion actively, which tells the nervous system, I own this, give it to me. This ties into the joint by joint approach because if I'm looking to improve someone's squat, let's say that's a high level movement, but let's say I'm looking to improve someone's squat. If their ankle doesn't move, I must go in and help that thing move, right? I think you can get too caught up and too far down the wormhole of saying, well, actually it's going to be affected by the midfoot, which is affected by this. Yes, they all tie together. But first and foremost, I want to say, does each part do what it's supposed to do? If it does, then I can right through that and start concerning myself with motor control and movement patterns and stability principles. But if that ankle doesn't work, I got to make sure that I get in there, whether it's with your hands, a tool, a band, whatever, and impart mobility. I think that in starting to view things this way and treat and assess this way, it's really kind of expedited things. It's regional independence before regional interdependence. You have all the prerequisite mobility, then I'm going to start more so concerning myself with how the parts play together. So those are two systems that they just fit together very, very nicely.
Very cool. Yeah, that makes a lot of sense to me. And, just with the squat, like making sure the ankle has that range of motion, check, open chain and closed chain.
Yeah.
And then work your way up. Is the hip, do you have good hip mobility? And then if they do, but they can't control it, all right, now we know that there's a stability issue.
Exactly. And that's when it gets fun, in my opinion. I love those motor conditions. I love it. So fun.
That's right. It is fun. Because that's the part where we actually kind of like, to me, it's like you're really like teaching and they're learning.
Yeah. And quick, It's happened so fast. It ties in really well with tape too, which is, a bonus for me. But you see change happen so fast and that light goes on in their head and they're like, holy smokes, what just happened? That was awesome.
Mind is blown.
Literally, it's awesome. Definitely awesome.
Very cool. Why don't we just continue with FRC a little bit and then we can circle back to the other stuff since you brought it up. That was a good segue there. So you've gone to that seminar, that course. So what is kind of what is FRC? What does it stand for? What are some of the principles that Dr. Andrea Spina teaches under that system, and kind of what are some examples? I guess you could share that you've used with students or clients?
Yeah. So FRC stands for Functional Range Conditioning. He kind of has two branches with Andre Ospina. He's Dr. Andre Ospina. He is a chiropractor out of Canada. He kind of has two branches of courses. One is his FRC course, Functional Range Conditioning, and the other one is his FR course, his Functional Release. And that's the manual course on how to do soft tissue work to help with mobility restrictions. I have not taken that course. I've taken the FRC course. I was more interested in that. And he has a kin stretch course that they put out, which ties into the FRC course. And the basic principles, for me, if I was to try and summarize it, is looking for a better way to gain and maintain mobility, right? Not flexibility, not just this passive range over which we have no control. Increasing our mobility such that my active range is as close to my passive range as possible, and I own the entirety of that range. That not only decreases my likelihood of injury, right? Because now I'm better able to control my entire range, but it allows me to keep my mobility. Like I said earlier, your nervous system always wants to feel safe. You can have a ton of range of motion, but if you don't own it, right, or you can try and impart a ton of range of motion, but if you don't tell the nervous system, I'm safe here, you're going to be okay, it doesn't want to remember that, right? Same way you don't want to remember your nightmares. Neither does your nervous system. It says, this is scary for me. We're going to forget about this. So within his system of, activating at end range, activating throughout the entirety of the range, we start to see a more effective, efficient way of imparting mobility. And it's nice because you can do it on yourself. It's an active thing. It's not like, I need to have my therapist there with me to do this. This is a practice that you can do on your own. His kin stretch class, I think I haven't taken it. They kind of introduced it when I took this course. It wasn't quite developed yet because it was a little while ago. But his kin stretch class kind of seems to be yoga on steroids. And I say that in a good way. Or perhaps even better way to describe it is it's the way yoga was intended to be. I think that people have taken yoga and kind of turned it into a let's hang out on my end range and kind of hang and see how far I can stretch, where instead of being active throughout the entirety of this range. And kin stretch just looks to highlight that. Be active throughout the entirety of your motion, your movement, your motion. And, he's great because the course is great because for those people that are really into studies and things like that, I'm not one of them, but for people that are, he presents a lot of the science behind it, and it's sound and it makes sense. And you're like, you hit yourself in the head when you take this course. You're like, duh, this makes total sense. You're just like, oh, of course, like activated end range. And so he gives you a lot of practical applications, and he gives you a lot of examples for each of the different joints and things like that. And you go through that course and you're just neurologically exhausted by the end of it because you're doing a lot. You're really activating throughout the entirety of new ranges of motion that you're like, wow, this gets me.
Are you doing that as you activate through the end ranges or going through a range of motion for the joint? Are you doing it through creating a lot of tension?
Yes. So there is, and I think that part of this is kind of where I had a little bit of contention, a point of contention with me. He talks about irradiation principles. So for those of you in the kettlebell world, it makes total sense. And it's like, yeah, I want to contract this area. It starts to spread to other areas. I think that it's important to not let it go so far that you're holding your breath and turning red and things like that, which is what I saw a lot of in the course. Because people are just like, I want to get that range. I am all about the nervous system. And to me, if you're holding your breath, you're entering more of a sympathetic state, that flight or fight state. It says, I'm scared. So the nervous system doesn't want to as readily remember that movement pattern. Whereas if you make sure you can breathe, we're more in a parasympathetic state, but we're still contracting things. Nervous system learns best in that state and remembers best in that state. So we are generating a lot of tension. Absolutely. And it's a lot of focused, targeted work. So we're not getting a lot of compensations. Like if you're working on your hip, you're not getting a ton of thoracic and lumbar movement. We're trying to go isolated just to that articulation, just to that joint. Mm-hmm. But I think that it's important to make sure that we're not creating so much tension that we're like having, an aneurysm. Fine line there.
Right. Yeah. You don't want to be turning, as red as a tomato or something.
Exactly.
Right.
Exactly.
No, that makes total sense because that's the same thing. Like even in Strong First, when you're using irradiation or the power breathing, putting yourself under tension, that you're actively, taking a breath in and then either letting hisses out or one continuous hiss. So you're really not trying to hold the breath the entire time.
Exactly.
You don't want to do that. Yeah.
Exactly.
Very cool. So how has that helped you with students or clients?
The biggest way that I use it, it's great for treating your own pain, especially in an acute manner, because he talks about gentle isometrics, which is a great thing to introduce right away. Right? Obviously, if you're in so much pain you can't do anything, all right, so give that a little bit of time and respect it. And then I can start reintroducing force is what I want to say. I can start reintroducing force to those tissues, right? That's how we build resiliency, is we stress an area. And so we can graduate that or have graded exposure to that and start off with less and then, gradually increase that. But, Joe Lavaca posted a great post about this the other day, and he had some ankle pain and he started off with gentle isometrics in addition to, Rocktape and other things. And it fits within the system because it's like, all right, I can treat the pain, the chemical pain. I'm going to start loading these tissues. That's going to help build resiliency. So when people come in and they're having acute things, that's what I'm going to start them off with. And then in terms of, I'm working on mobility, because so many people have mobility restrictions, I can have a system that they can do this on their own and start to see objective gains and objective changes. I probably use it the most myself on my ankle. I have my left ankle doesn't move as well as my right. It's kind of a chicken or the egg thing. Like I sprained it twice during college, but it's also my ACL side, and I think that the knee has something to do with it. So, there's a little bit of everything going on there. But just working on activating at end range to gain more dorsiflexion is huge. And clinically staying with the foot, I guess, if you will. This concept of getting out of neutral and loading tissues to build a more resilient human. I did a DM the other night, nobody sprains their ankle in subtalar neutral. And yet we spend so much of our rehab sticking you in that position and say, stay here, stay here, stay here. I want to see, can you control yourself, control your movements and attenuate those forces when we fall out of neutral, right? That person with the ankle sprain has decreased proprioception in that area. Yeah, some ligamentous laxity and things like that. What I need to start doing is getting them to that end range and progressively loading it. And making that system more physically more and physiologically more resilient, so that if they do go to run and they hit a root and their ankle rolls over, one, they have the neurological drive and proprioception to be able to control that movement, and two, the tissues can withstand that. So it has had great carryover to a lot of what I do. It's one of the best ways, in my opinion, to work on gaining mobility.
Awesome. Yeah, and I like the emphasis on, displaying and having the ability to control yourself, because that is true inherent mobility, right?
Exactly. Can you control it?
Yep. Very cool. Very cool. Okay. So since you brought up the ankle and the foot, let's talk about that, because that's on the list. Okay. All right. So, that's one that I have too. Similarly, my left ankle. I fell years ago. I was going to set the dining room table at my aunt's for a holiday dinner, and it was 2 steps down, and I completely forgot and just whiffed and missed the steps and rolled my ankle. Yeah. Oh, it was bad. Yeah. Oh, yeah. There's a reason I rode. I was not the most coordinated person. Okay. So, but I never got it checked out. Regret doing that. Because I probably had some either ligament or some type of damage, because I remember that happened right around Christmas, and it was pretty much in a swollen state up until June. Mm-hmm.
Absolutely.
Yeah.
Absolute ankle. Absolutely.
Yeah. So, let's talk about the foot and the ankle. I think one of the big things to start off with is the fact that the foot and the ankle moves in triplanar motion, which a lot of people don't necessarily either know or they think about when they think about the foot. So, one, why is that important? And then two, how does that affect everything else up the kinetic chain if we have something that's kind of off at that area of the body?
Yeah, I mean, the foot is so remarkable. We have a structure that needs to be rigid, that also needs to be supple, that absorbs force, that transmits force, that allows us to propel ourselves forward, and is our first point of contact with the ground when we're standing up or walking or anything like that. And so obviously any dysfunction down there is going to ripple up the chain because, like I said, we are not Mr. Potato Head. It is all connected. One of the main ways that I'm seeing it currently that I deal with it, obviously with running and jumping like that, that's huge. But the main demographic that I was treating before I left was a lot of CrossFitters, and the squat. That's a big thing for people, is the squat. Can you squat? Basic human function that most people have lost. And so one of the things that we're seeing in terms of it manifesting up the chain is if I can't dorsiflex my ankle, my squat is going to be greatly affected. I'm going to end up compensating typically by leaning forward more in order to maintain my balance. I can't keep my chest up. I can't have that thoracic extension, which is going to make lifting anything overhead basically impossible if I'm in that deep squat position, whether it's a snatch or an overhead squat or anything like that. And in terms of the triplanar motion, one of the things that we see is compensations occurring, and when I look to intervene, right? So we can talk about the lack of dorsiflexion that occurs at the talocrural joint, right? Sagittal plane motion. Oftentimes I don't have that. And so what the person does is they rotate their foot to the outside, right? That means I don't have sagittal plane motion front to back. So I rotate my feet. I'm bleeding into the transverse plane and the frontal plane somewhat there. And then I just start collapsing through my midfoot, right? But that allows me to get into that deep squat. That's a big compensation, a big problem, because now I've lost tension in the system. I start taking more stress up through my knees. They start collapsing inward because I can't generate the same torque because I have this dysfunction within one part of my ankle. And so people try to correct the squat. I'm going to put you in this position, or we have to look and consider, like you said, the foot, the role of the foot and the interplay within the foot and the ankle, and that triplanar motion, and assessing how is this joint moving? Is this joint moving because it's picking up slack for that one? What's once again, regional interdependence and regional independence. And that's probably the biggest way that I'm addressing it or attacking it or seeing it presently. When it comes to running and more dynamic stuff, it gets really complicated and really fun. But that's probably the most basic example that I can give as to how dysfunction in this one area can lead to back pain, right? Because I start bleeding into other planes and stealing motion from other joints, and now I got pain.
No, that makes sense. Yeah, for sure. So you were abducting and then going into pronation a little bit.
Yeah, exactly.
So, one thing that I've been thinking about more now in regards to the foot is, also taking into consideration the hip structure, right? So I don't know if you saw that article. I guess it came out like a year ago, but why people must squat differently, and looking at the depth of the hip socket as well as the length of the acetabulum, and how that plays in. So that obviously is going to factor into foot position. Some people may need to turn their feet out. So if you are working with, say, a CrossFitter or another student or client, what are some things that if they want to try to improve their squat, what are you looking at from a assessment or evaluation standpoint to determine or take that into account? Their
absolutely. And that's and I get that question all the time, and that ties into the butt wink and things like that. And they're like, oh, but my hips. I can assess that very quickly. Regional independence before regional interdependence. Let me just see how your ankle moves. Simple closed chain dorsiflexion, knee to wall test. Let's just see quick and dirty how you're looking with that. Let's see your knee mobility. It's typically not so much of an issue. And then I can assess your hips. I can put you on your back. I can put you on your stomach and do something like a Craig's test, which you learn in PT school. That kind of assesses for torsion at the femoral neck and kind of the angle that's present that may predispose someone to having their feet turned in or turned out. Yes, hip socket architecture is going to make people squat differently, make people squat look different. But a lot of that can also tie into adaptation. And we've stopped going into that position, and now I don't have it. So I think that it's a fine line to dance where people don't want to work on their mobility because it's very difficult. And if you do a kin stretch class, it sucks. You're like, I'm so tired. So it's much easier for me to just squat like this. Whereas some of it is soft tissue adaptation. Yes, typically, a Caucasian hip socket can be a little bit deeper. And so I can't get into the bottom of the squat as nicely, and maybe I have to turn out a little bit, versus an Asian hip socket, it tends to be a little more shallow, and I can get into this position a little bit easier. Yes, of course that exists. But I want to see and kind of start to assess does it feel bony? Does it feel soft tissue? And we learned about that in PT school. When you assess someone's joint, like, what that end field is like. If this is bony, that's probably not going to change. This is more soft tissue. Perhaps there's some wiggle room with that. Someone just did a great article about it, and I'm totally blanking on his name. It will come to me. I read not too long ago about assessing the squat versus loading the squat. And I like to see, do you have the mobility to enter the unloaded air squat with the feet facing forward? When we start to load that pattern, and I'm doing a snatch, a clean, a back squat, loaded, then yes, we can talk about turning the feet out, because also that gives the joints and the soft tissue more of a mechanical advantage. But for the most part, I do like to assess, and that's the standard they use for the FMS and things like that. I do like to assess to see what's going on, because some people will assume I have to squat with my feet out because of my hips, and actually, like we just give the example, it's because your ankle's crap. Right? You're turning out because you're cheating, you're bleeding through the midfoot, that you don't have your ankle motion. So quick and dirty, I can break that out and say, hey, this is what it feels like. This feels more like a bony joint thing within your hip. And so for the person that's trying to improve their squat, and I get inquiries a lot on social media, is like, get assessed. It's tough to find a good provider, I understand. But get assessed. A good practitioner can break this down for you very quickly and let you know, like, hey, this is where you should be working on more. Stop smashing that hip because it has bone and it's not going to change. Or, hey, yeah, you can go after this a little bit, and maybe FRC principles is what you want to be using. But that's what the number one thing that I would say is get assessed and figure out mobility at which area, or is it a stability problem? And then you can go from there.
Awesome. Love it. I love the fact that you give people actionable steps that they can take. Beautiful. Okay, next topic. All right, we're going to shift gears again. So let's talk about the pelvic floor and pelvic floor dysfunction. So who would potentially have pelvic floor dysfunction, and why? And then what are some symptoms, and then what is your approach to it?
Yeah. So everyone has the pelvic floor. So anyone could have dysfunction and symptoms. And those dysfunctions and symptoms range from pelvic floor pain, sexual dysfunction, to, postpartum, obviously, to constipation issues, post-prostatectomy. They have people having their prostates removed, men having their prostates removed. You can see a host of problems. And so I like to say that like you said, I treat the pelvic floor. I'm a pelvic floor physical therapist, as opposed to a women's health physical therapist, because I don't just treat women. I treat men that have dysfunction too.
Sure.
In terms of how it presents, it could be pain, it could be loss of sensation. Like I said, it could be sexual dysfunction. The big one that's getting championed right now and putting out there, and obviously because I'm around it more too, is pelvic floor dysfunction in the female athlete, with things like box jumps, double unders, heavy squatting, things like that, when they're having urinary incontinence while performing these movements. As for why it happens, it can be one of a few things. Everyone tends to assume, it's because the pelvic floor is weak or loose, and so I need to do Kegels or however you pronounce it. And that's really not always the case. Tying back into what I just said before, you always have to get assessed. Sometimes what's happening is that actually the pelvic floor is too tight, and the person's been bracing a lot with this pelvic floor. And so when they go and jump and put pressure through this, it doesn't have the strength to push back. Oftentimes a tight muscle is a short muscle. Think about that length tension relationship of things. And so the person goes and does like a million Kegels every day, and they don't get any better. I did DM about this. Telling someone with a tight pelvic floor to do Kegels is like telling someone with a tight bicep to do bicep curls. It doesn't make sense. But you have to assess first, say, oh, it's tight. Let's figure out how to relax this. And then I can intervene with strengthening or contractions for the pelvic floor. One of the ways that I treat it, like obviously I can do internal work. It's not the first thing that I go after, is working on integrating it within the system. It's unfortunate that the pelvic floor is taught as such a separate entity. Like it is part of your core, it's part of your body.
Yep.
And we learn about it. So you wouldn't have a whole unit on just your elbow, right? Like it's some different part of your body that needs to be taught separately. And yet when we learn about the pelvic floor, if you get it, you're lucky enough to get it in school, it's its whole separate thing. And you almost miss the fact that it needs to be, that it is integrated within the system and integrated with your day-to-day functionality. When you breathe, your pelvic floor is going to descend and you exhale and it rises back up. When you're trying to brace for something, right? You're creating that intra-abdominal pressure and we're doing Valsalva maneuvers and wearing weight belts and things like that. You are affecting the pelvic floor. And so one of the things that I do to treat is one, work on educating people so they know what the heck it is and what it's supposed to do. And then working is crazy, right? Just to give some awareness there. And then work on breathing to kind of integrate it within the system. And then we can start working on other things and bracing techniques, especially in this functional fitness world where they're trying to lift heavy things on their back. You take a toothpaste tube analogy, that's kind of like your core. If I don't have strength or good mechanisms for bracing, what tends to happen is I put that weight belt on and I cinch that in the middle. That pressure is either going to go up or down. Typically, we're pretty good on the top. That'd be kind of like your glottis and your diaphragm. I'm good at locking that down. The bottom suddenly becomes the escape point for that pressure. And that's when we start to see urinary incontinence and things like that. It tends to happen more with females simply because of the anatomy, right? It's a kind of a questionable makeup there. But, short urethra, you have a hole basically on the bottom of this toothpaste tube. That's where the pressure is going to go. So typically when I'm working with people, I look to regress to progress, start getting them, more in tune with things, getting things relaxed. Then I can work on strengthening, integrating it with breathing. And then we work on proper bracing strategies and, integrating it within their jumping and running and heavy lifting.
Awesome. That was great. Thank you.
Yeah.
Do you typically see that more in from certain demographics or populations like CrossFit, or is it anybody? Like I know you mentioned postpartum as well.
Yeah, it's something that's just not talked about. I see it a lot in CrossFit and box jumps. One, because of the demands of the tasks that they're asking for in CrossFit, but I'm seeing it more in CrossFit because people are starting to talk about it, and I encourage people to talk about it and not let it be this like hush hush secret, because it's a problem, right? And part of it also is that as a female issue, and not to like be all like feminist on you or anything like that, but as a female issue, like it gets swept under the rug, and women have adopted it as normal instead of common. Right? Common and normal are not synonymous. And it's very common to have urinary incontinence, especially after pregnancy, right? That's huge trauma to the pelvic floor. It's not normal, right? We shouldn't just say, oh, it's normal and this is how you meet for the rest of your life. No, you should be getting in sooner rather than later. You go to France, every woman has 8 to 12 visits of pelvic floor therapy after having a kid, because that's a huge trauma to your body.
Wow.
So it's crazy, right? In the States, half the women don't even know about it. Half doctors don't even know about it. And so people, you ask women who've had kids, or they talk about with their moms and things like that. And they're like, oh, yeah, this is what happens. No, it's common, not normal. So that's a huge demographic that I'm seeing it in, but only I think because it's coming to light, not because that's the only people that experience it. It's super common, that particular kind of pelvic floor dysfunction in terms of, urinary incontinence. But it's also common in men to have, pelvic floor pain, but they don't want to talk about it. And a lot of it is because we treat that area, we treat the pelvic floor with such like a hush hush, I'm not going to bring that up. And, people are living with this dysfunction. As the discussion gets out there more, as there's more awareness raised, you'll start to see it in more populations. Absolutely. It's just a matter of people aren't talking about it.
Well, I'm glad that you're being at the forefront and making sure that people shouldn't be feeling like this is an awkward subject matter to bring it up, because it is an important issue. And I've had some friends that have had it. So I actually caught like one of your social media posts, and that's why I wanted to make sure that we discussed it, because I know that it's affected some people that I know. So
absolutely,
it's important. It's important that we address it and talk about it and make sure that people are becoming more educated about it and knowing how to deal with it and find help.
There you go.
So
there you go.
If we if I had a pelvic floor dysfunction, what would that feel like in terms of like sensation or pain, so that people may have a better idea of like how to identify that, and then they could obviously go to a practitioner and get help.
Yeah, I mean, it's going to present so variable. The same way like someone's knee pain, two people's knee pain is going to present very differently. Sure. It could be burning, it could be loss of sensation, it could be dull, achy pain. There's a book called A Headache in the Pelvis, because some people have this like chronic, persistent, low-level pain. It could be sharp stabbing pain. It could just be simple, incontinence without any pain. It could be a prolapse where this is again more typical in females because of the anatomy, where you start to actually have the internal organs, whether it's the bladder or the uterus or the rectum, kind of bulging or pouching through or pushing through and escaping and kind of prolapsing towards an external position, right? Sometimes sometimes it actually comes all the way out. Sometimes it's just a descent of these organs, and so there's a feeling of heaviness within the pelvis because things aren't kind of where they were before. It can be very, very varied. It could be the type of thing where there's a hypersensitivity, and the people can't tolerate wearing underwear. They can't ride a bike. They can't sit down. It could be a feeling of tightness. And inability to tolerate any kind of penetration in that area or any kind of touch. It's very, very varied. Basically, I tell anyone, if you have pain, we shouldn't have pain, right? Like we really shouldn't, whether it's in your elbow or in your knee, you shouldn't be having pain. And so if you have pain, you want to get in and see someone. Oftentimes the thing that happens is this pain gets misdiagnosed as either a UTI or a bacteria, an infection, a yeast infection, or bacterial prostatitis, and that's actually not what's going on. It's there's pelvic floor dysfunction, which can manifest and look very similar to these other conditions, and so they go untreated or incorrectly treated for quite some time, and that causes things to get worse. So again, it becomes a matter of empowering and educating the patient, because sometimes some doctors don't know about it. And, I don't say that in a bad way, but some doctors don't know about pelvic floor dysfunction. They don't know about pelvic floor physical therapy. And so I encourage you as a patient, or as an individual that may be suffering, right? This is for anyone out there that may be suffering with that. Do your homework, do your research, and look to go and see not only your doctor and ask them about pelvic floor physical therapy. And if they don't know about it, you can ask another doctor, or in many states, you can go to a physical therapist first. A lot of states have what's called direct access, where you don't need to go to an MD first and get a prescription. You can go right to the physical therapist. So, be your own best advocate. If you have a pain that it's being diagnosed as an infection and it's not going away and it's been there for a while, we should start thinking about other things possibly going on, because it can manifest as UTI, yeast infection, prostatitis, and that's actually not the cause of it. It's pelvic floor dysfunction.
Well, I'm so glad that you shared that, because that's I'm sure there's probably some people out there that may potentially have been misdiagnosed, or even are confused, and they think it's some of those symptoms for the different afflictions you've mentioned, and it could very well be pelvic floor dysfunction.
Yeah. One of the best resources that I've found for it, because there isn't enough out there yet, because it's coming to the forefront now, pelvicguru.com. It's a colleague and good friend, Tracy Scher. She's like just a big name in the pelvic floor game. That's a great resource, I think, for people to kind of start And she has a lot of other resources on that website of books to read, of doctors, of just connections and things like that. That I think starts as a nice, because that's not my main thing that I do. It's a small part of my practice. That is what she does though. It's pelvic floor dysfunction. So yeah, pelvicguru.com is excellent resource.
Awesome. And I'll be sure to include that in the show notes for the episode.
Awesome.
Very cool. Thank you. Okay. So shifting gears again. So we talked about this briefly offline before we started the interview. So how do you go about looking at and determining if an individual has an inherent mobility, like a joint or soft tissue restriction, or it is a true stability issue, or motor control? So I'll let you take it away from there.
Yeah. So my foundation for school, for education afterwards, it comes from the SFMA, the Selective Functional Movement Assessment, Gray Cook stuff. And it's a nice system to try and assess whether things are a joint mobility / tissue extensibility problem or a stability motor control dysfunction. I tie that in with Andrea Ospino's work, a concept of regional independence before regional interdependence. And the whole time I'm kind of also remembering that if you have a mobility problem, you typically have a stability problem somewhere else that I also need to address. But main thing with addressing or assessing to see, is it primarily mobility, primarily stability, is looking at each joint, saying, is it doing what it's supposed to be doing? Can it go through that range of motion, both actively, passively? If it can, and I clear all those joints and try to have them do that movement pattern again, and they still can't do it, right? But all the parts are physically able to do what they're supposed to do, then I start thinking that it's more of a stability or motor control dysfunction. So what I'll do then, very simply, is unload the pattern or take it to a position that has less postural demands. So an easy example is a toe touch, right? Everyone should be able to touch their toes. A lot of people can't. But to unload that pattern, right? A toe touch is a nice shape where I'm bent forward, my hands are touching my toes. I could unload that or reduce the postural demands by putting that person on their back, right? I put the person on their back and have them lift their leg. That's going to end up being the same shape as if I was standing up and bending forward and touching my toes. However, I've reduced the postural demands. I've reduced and changed the way that gravity is acting on the body. I've made it feel safer. I've made the nervous system feel safer. You're on your back, which means you can't really fall over. Nice and easy. Your nervous system says, okay, this is not so bad. If the person has more range of motion while on their back in that gravity reduced or changed position, that speaks to the fact that it's likely stability motor control dysfunction. All right. If the person has the same amount of motion that they did when they were standing up, they still can't touch their toes, they're not coming close, that leg doesn't go up to 90, then it kind of confirms the fact that it's likely more of a mobility issue. But like I said, majority of the time, in the absence of prolonged trauma or prolonged immobilization or direct trauma, a mobility loss is typically preceded by a loss of stability somewhere else. So this tells me I must work on that mobility and kind of get into that area, get into that tissue, that joint, whatever. But I got to think about imparting stability concurrently somewhere else. So within that toe touch example, that person can't touch their toes. I put them on their back, try to lift the leg, it still doesn't go up that far. Speaks to more of a mobility dysfunction. So I'm going to work on, soft tissue, whatever, along that superficial back line or tissues, whatever. And then I'm also going to think about, I need to figure out kind of why that mobility was lost in the first place. Sometimes we see with the hamstrings that mobility is lost, or with the toe touch that mobility is lost because I don't own my midline sequencing, right, my core, quote unquote. So the nervous system says, you don't own this, you're not safe, I'm not giving it to you. The easiest way to impart stability is to take away mobility so I can make your hamstrings tight. And now you can't bend forward and hurt your back. So if I think about that, I'm going to work on that tissue, affecting whatever change locally you may think that is happening, whether it's neurologically or mechanically or probably both. But I'm also going to impart stability, within the midline while I'm working on this stuff. So I'm to have more of a complete approach, making the nervous system feel safe, owning the entirety of the range, and also trying to affect change within the tissue to help on that mobility.
Awesome. I love it. I love listening to your responses because I'm just like taking taking it all in like a sponge here. I'm learning. It's good. It's good. Fantastic. So
that course, the SFMA, sorry to interrupt, that course is probably one of the main inquiries that I get from people on social media is courses that I recommend. And that's a good course. It's really nice. It will not give you any new tools for your toolbox. It will simply give you a new way to rearrange your toolbox. And that's about efficiency. Again, it gives you a nice model to break things down. Is this a mobility restriction, whether that's soft tissue or joint, or is this a stability restriction? That's causing the movement dysfunction, and that's going to allow you to attack the problem most appropriately. I had an attendee at the course I taught just recently, my Rocktape blades course. She was clearly hypermobile, so my head kind of automatically goes to more of a stability issue, but we can't assume. She's doing overhead squats and just kept saying, I feel it in my mid back. I feel it in my mid back. Man, my back is tight. If I was to just assume that and treat this as a mobility restriction and go after that thoracic spine, I would have been going down the wrong path in her case, because with a little more assessment, we took her and we reduced the postural demands and saw if she could get into the squat position within quadruped rocking. We cleared all the joints, ankle worked, knee worked, thoracic spine worked fine, hip had great mobility. That says to me it's likely not a mobility restriction. So what we did was we imparted some stability to the system. In this case, we did some tool work to her midline just to kind of activate the receptors there that say, hey, pay attention. Let's start firing, right? I could have used tape too. We had her squat again, and she felt no pain in her mid back, none, no restriction, no tightness, and that makes sense, right? The easiest way to impart stability. The easiest way for your body to impart stability is to take away mobility from somewhere else. She had all this range of motion. She's a loosey-goosey kind of gymnast. And so what was happening when she was doing her squat was literally she was arching at her upper back to try and create stability there and trying to keep her chest upright instead of being able to reflexively sequence through her midline to hold herself upright. I started imparting stability to the system. I bring some awareness there, use tape, whatever, use a tool technique. When I say tool, I mean literally doing like an I-stim technique, instrument-assisted soft tissue mobilization, to her midline to prime that area. She's able to hold herself up better. She doesn't need to lock into her thoracic spine, and she doesn't feel that restriction. So, assessing to see whether it's stability or mobility doesn't take long and can absolutely save you so much time with treatment because you're out attacking the proper thing.
Awesome. Yes, that's the SFMA. That's I believe it's just open to like clinicians, right?
It isn't. It's open to everyone. When I took it quite a few years ago, and we had a bunch of trainers in there, and there's always a point of contention, like, oh, should trainers be able to take it? The problem that happens if you don't have a license to touch, right? You're not a massage therapist, you're not a PT, you're not a chiro, is that when you do these breakouts, if you come to a section that says this is a mobility restriction, in theory, then you can't use a manual technique to help impart mobility. But that's not to say that you can't to show your person how to use a band or use a ball to help themselves with that mobility. I'm writing a piece right now about that and whether or not courses should be open up to trainers and PTs. And because you go into these courses and it's funny, like PTs almost get, and I'm a physical therapist, obviously, physical therapists almost get uncomfortable when they see that there's a lot of trainers in the course. And they're like, what are the trainers doing in there? The better question is, where the heck are the rest of the physical therapists, right? Like, you want to learn as a personal trainer? Great. Because they're going to get that information from somewhere else. So at least now I know that's coming from a credible source. And then it's up to the trainer and whatever practitioner it is to know their limit and to know their scope of practice, whether it's that I can't dry needle or, this person can't do a manipulation or that person can't touch. Okay, so then you work within the system and then you stop and refer out once you get to there. But I'm by no means about withholding information. It's you just gotta kind of put the onus on the person taking the course to know their limitations and say, yeah, I have enough understanding of this, but this is where I refer out.
No, absolutely. Yeah, you gotta make sure you stay in your lane, so to speak.
Yeah, that's it.
Cool. Anything else that you want to touch on, topic-wise?
Nothing to go too deep into, just in terms of my own practice philosophy. We've hit on a lot with the pelvic floor and joint by joint, regional interdependence, Rocktape. I am all about breathing and scar work. But breathing is a lot easier, I think, for people to kind of grasp how that affects movement and the body. And it's something that I wish that if I could go back and start treating again, that is what I would work on. It took me years to actually understand and value and be comfortable enough with working on that within my own practice. And it's become such a hot topic now. Everyone's talking about breathing. But it really is a game changer, and it is the first thing that I work on or assess in any treatment or assessment or anything, because it's the most functional, most foundational movement pattern that we have. And if we don't work on that, as Greg Cook would say, we're stacking performance on dysfunction. So I always go back to the breath and the diaphragm and how we're breathing. And I encourage listeners out there to look up things like PRI, Postural Restoration Institute, or just read. There's tons of stuff out there everywhere, and start valuing breath work and proper functional breathing patterns.
No, it's so important, because then as you kind of you progress with any type of lifting, it's not necessarily, I shouldn't say it's not emphasized, but it kind of gets pushed to the back. It's not up front anymore, and the breathing is very much around a lot of the execution of the reps, right? Or the lift. So that's super important. That's how you're, creating stiffness in the trunk, and that's allowing you to really, develop power and move velocity at the shoulders and the hips.
Absolutely. And people kind of think that I'm only about like performance or like athletes. This is what I'm working on with everyone. Whether you come in and you have knee pain, you have shoulder pain, or you're trying to snatch 500 pounds, 300 pounds or whatever, I'm looking at your breathing first, because that will affect everything. Pelvic floor dysfunction, chronic pain patients. I am looking at that breathing because it's so integral.
Awesome. Got to own the fundamentals.
That's all right, my man. You know it.
You ready for the rapid fire?
Let's do it.
Sweet. Here we go. Okay. So, based on your life experiences and your knowledge, if you could go back in time, what advice would you give yourself 10 years ago?
Work on breathing. Work on breathing. Absolutely. For my own physical dysfunction, and then starting to integrate that within practice and helping people get better quicker, work on breathing.
Awesome. You got to pick one. What's your favorite strength training exercise?
If I had to pick one thing that I said I'd only do for the rest of forever, it would be a Turkish get up.
All right.
It covers everything.
Cool.
It hits everything.
Cool. I was wondering if you were going to say like handstands or handstand push-ups, because I've been seeing it a lot on Instagram lately.
Yeah, I'm trying to work on that. But the Turkish get up, man, that's so functional. It gets everything. Beautiful movement.
That's my favorite too. Okay, how has your training changed today compared to 10 years ago?
More varied and more targeted. Before I just kind of based things off of my athleticism and just did more. More is better. More is better. Better is better. All right, and it's become more generalized. I'm doing handstands. I'm running sometimes, not as much. I'm lifting heavier weights. It's more targeted and more targeted, more focused, and more varied at the same time.
Awesome. It sounds like it's been more rewarding too.
Absolutely, my man. Feeling the best that I felt ever.
Awesome.
Yeah, it is, man. It's awesome.
That is awesome. That's what I like to hear right there. That's very
awesome.
Cool. Okay, so you touched on this. So you had an ACL injury. So how did that injury affect your training or change it?
It changed my life, Joe, not just my training. It happened when I was 15. I was in my head going to go to UNC and play professional soccer after that, but also be an orthopedic surgeon, right? Soccer was everything. I was going to do everything, right? 15 years old, you're invincible. It changed everything. Absolutely everything. I basically just wanted to get back to playing soccer because it was a big recruiting year. And it still didn't teach me enough to be like, hey, you tore this because you move poorly. I was too young for that, and I don't think that the science and stuff was out there enough about it. It has changed my training today because I have unilateral deficits or asymmetries, and I also see the importance of global movement patterns and moving well. Right? It's not just like being an athlete can be tough. Like, you're really athletic. Oftentimes they're like, just go do more, instead of, hey, let's make sure you move the best that you can. And it's changed my training in terms of, I need to move the best that I can, because that's actually going to allow me to do more stuff, not just let me try and do more. So the big game changer having that happen. Big game changer.
No, totally. I agree. Absolutely. Yeah. Okay. What's one thing high school athletes should be doing more of to complement their training and their health?
One thing they should be doing more to complement their training and their health. Obviously when you're young, you should be sleeping better and eating better, things like that. But I'd say within the training, there needs to be more unilateral work. There isn't enough. There's not enough unilateral. There's not. We don't do it.
So doing single leg work or single arm work. So instead of doing
absolutely
bilateral exercises, not that there's anything wrong with them, but
no, we got to do both.
Right. Just making sure there's an emphasis. Good. Awesome.
Absolutely.
What's your best tip to improve recovery after a training session?
I would say be mindful of rest and actually take rest. I think a lot of people, they don't recover because they don't give themselves time to recover. So there's nothing, rest is not a bad word. Off day is not a bad word, and stay active. Movement is the best medicine we have. Just vary it up. You don't have to go hard every day. I think that's the biggest thing, is actually take rest. You're not going to recover if you're like, oh, I'm just going to do like 100 wall balls instead of 500. Like, take a rest. It's okay. It's okay. You're not going to lose all your fitness.
I love it. What is your favorite meal?
Oh, man. My favorite meal, I would have to say poke. I hadn't discovered that until I came out here. Poke is basically sushi, but in a bowl, and I love it. I love white rice. Call me whatever you want to call me.
So it's kind of like a Chipotle bowl, but it's like sushi?
Yes, but sushi. That's exactly what it is. It's Chipotle bowl, but sushi. You pick what you want to go in there. I had it for dinner yesterday. It is the bee's knees, my dude. I love it. It's so good. They just put one in New York.
I think my head just exploded. Like, I'm thinking about that right now, and I'm like, what? But where can I get it? Who does that?
It's it's a West Coast thing. I think it's from Hawaii. I think it's a Hawaiian thing, and so obviously the West Coast is going to get it first. But it's everything, my man. It's definitely my favorite.
That sounds good. I'm like, oh man, I'm gonna have to do some research now on that.
Okay.
Okay. What's one book everyone should read? Does not have to be related to strength and conditioning or physical therapy. It could be of any genre.
It's going to sound so cliche, so don't hate me, but The 4-Hour Workweek. Tim Ferriss, he can be a lot to stomach if you can handle him. I can't personally listen to the podcast, but that book, I read it. I think it's like everything else. You have to read it at a time where you're open to accepting it, and the cards are kind of falling in place for it. But if you don't have to do those drills within it. I didn't do any of those drills, but just taking away the concept of there's more to this, and we don't have to work ourselves to death and doing things to make yourself happy. It's got a really good message. You have to kind of sift through some of the other nonsense, but if you can get to that and step, if you can step away and see the bigger picture, and you did it too, my dude. I mean, you took that leap. It's scary, but it changes your life, and it's worth it. And I think that's the message to be taken from that book. So I would say read that and take it with a grain of salt.
Awesome. Okay. Kind of building on that a little bit. Who do you study from, or who have you studied from in your career to continue to improve and get better?
I am always learning and always reading. And, in full disclosure, once again, I don't remember the last time that I finished a book in its entirety. I kind of read a chapter here, I apply it in clinic, or I see this, and then I put it down, and then I come back. I'm all over the place. Biggest name for me was Perry Nicholson. Stop Chasing Pain. He's my dude. He's my self-appointed mentor. And then from there, it's led me down a path of, social media. There's so much out there. Whatever tends to be trending, you kind of get an idea of like, hey, this is good. I should look into it more. Tom Meyer's work with anatomy trains has been huge. Looking into the Stecco's work with fascia has been huge. Ray Cook and all of his concept with movement, huge. I take a little bit from everything, from everywhere. I think that's kind of, allows you to get the most comprehensive, complete treatment approach, because there is no one size fits all approach. Like, this works for this person, this might work for that person. And so the more tools you have, the more views you have, the better. I'm actually another instructor at Rocktape, Adam Wolf, the biomechanical detective. I've recently linked up with him and we've been talking a lot. And he's a Gary Gray or Gray Institute PT, if you will. Mm-hmm. A lot of his foundation is there. And we've been talking a lot, and that's also, it's been good. That's probably the most recent thing that I'm doing a lot of work in and understanding is fascia with the Steckos and Leon Chaitau and then my dude Adam putting out good stuff. So a little bit of everything.
Awesome. Very cool. I'll have to check some of those out for sure. Add them to the always growing, never ending library.
Right? It never ends. I just buy these books and I'm like, oh God, I got to read this now.
That's ends. Right. That's right. That's good. It makes me feel better because I'm the same way. Awesome.
Exactly the same.
Well, Shante, I'm so glad that we finally got to do this. This was a blast. I will absolutely have to have you on again at some point in the future.
I thank you so much. This really was really fun. I like I said, I thank you for being so patient and keep continuing to ask me to do this, because it's been great. I really appreciate you asking me to come on and be on your podcast.
Yeah, thank you. No, the honor's all mine. So just hang on the line. I'm gonna hit the stop record button, but I'll give you a proper goodbye offline.
Sounds great, my JoJo.
I hope you enjoyed this brand new episode of the Leo Training Podcast. Be sure to tune in next week for another brand new episode. If you enjoy this content, I would greatly appreciate it if you would head on over to iTunes and drop in a 5-star review. Or take a moment and please share it on your favorite social media network, such as Facebook, Instagram, or LinkedIn.
Thanks for listening to the Leo Training Podcast. Subscribe and get even more expert training tips at www.leotraining.io.